Hey, everyone, for the second morning session today. Not sure what the guy was talking about. It was here right before the break. Obviously, fake news anyway. So I'm the real Matthias Arnold, and it's my pleasure to be here. Really, thanks for the invitation. And I'm not going to say much more than that, except for the reminder that we will have all three talks in a row and have a joint QA in the end. So note down your questions if you have any. I will give each of the speakers 2 minutes warning for the end of their presentation. And with that, it's my pleasure to introduce our first speaker. That is Nick Bishop, Associate Professor for Human Development and Family Science from the University of Arizona. Nick, the stage is yours.
All right, thank you. Hello, everybody. It's Dr. Nicholas Bishop. You can call me Nick. Dr. Nicholas Bishop, and name again. I'm happy to be here, and I'd like to share my collaborative work. It examines the association between multimorbidity combinations and cognitive trajectories amongst Mexican older adults using the Mexican Health Aging Study. This is collaborative work that was developed with a great group of co-authors, and I want to acknowledge them before I begin. So to start, I do want to reiterate that this study and the work that I'm doing focuses on Mexican older adults that were primarily born in Mexico or lived in Mexico. This is, not related to Mexican Americans. I can talk a little bit more about that interface later, but I think that's really important to convey to begin. So in Mexico, there's kind of a growing need to address chronic diseases that are related to aging. Mexico's population of adults aged 65 and older is projected to increase from around 10 million in 2020 to more than 27 million in 2050. And in addition to an aging population, Mexico is experiencing a simultaneous epidemiological shift from infectious and communicable diseases to chronic diseases of aging. These are both happening in the context of limited public resources and insufficient governmental responses to address the needs of an aging population. And this is really kind of the call to arms and the reason this study I think is important. So of the most debilitating and burdensome age-related health conditions, cognitive decline and dementia really stand out. And I'm speaking to obviously peers that understand that. Dementia is really important to consider given the heavy burden faced by the individual affected by the condition, the high level of support that's required from their social and caregiving networks, as well as the high cost to the economies and the health systems in which that aging person is embedded. For example, people or persons in Mexico with dementia have been found to have healthcare costs about 60% higher than those without dementia. And it's estimated that around 7% of Mexican older adults experience dementia. Given these individual and public costs related to dementia, it's imperative to identify potentially modifiable risk factors that can be targeted to reduce the risk of cognitive impairment, especially given the lack of effective, pharmacological and clinical treatments. An especially promising pathway to reduce cognitive impairment in aging populations is by targeting other chronic health conditions, and this is something the prior speakers kind of touched on with these comorbid chronic conditions. It's been established that the presence, duration, and severity of other chronic conditions act both independently and in tandem to influence the risk of cognitive impairment. And this suggests that examining constellations of chronic conditions as they relate to cognitive decline might provide insights into levers that can be pulled to reduce the impact of cognitive impairment in aging populations. For example, type 2 diabetes, which moving forward I'll refer to just as diabetes, is a well-known risk factor for cognitive decline. Diabetes has been linked to cognitive impairment through mechanisms including hyperglycemia, insulin resistance, inflammation, and vascular damage. Diabetes may play a particularly important role in cognitive impairment among aging Mexican adults, as diabetes is Mexico's leading cause of morbidity and mortality. And rates of diabetes are higher in Mexico than other parts of the world. Now, adding to the importance of examining this link between diabetes and cognitive decline, The Mexican population of adults age 50 and older that's affected by diabetes is projected to increase from around 19% in 2012 to about 34% in 2050. Depression is another well-known primary risk factor for cognitive decline. Globally, depression accounts for between 4 and 15% of the population attributable fraction for dementia and increases the risk of dementia by at least 40%. A large proportion of Mexican older adults report experiencing depressive symptoms, with between 17 and 30% being identified with depressive symptomatology. Given the relatively effective treatment options for depression, and I say, I emphasize relatively, this condition represents a potentially modifiable risk factor for non-normative cognitive decline. And this would make it a primary target for treatments and interventions. Several other chronic conditions have been shown to have independent associations with the risk of dementia and cognitive impairment. We talked about this cardiovascular multimorbidity and its relationship to cognitive impairment. This includes conditions such as hypertension, heart conditions, and stroke, and these are each related with cognitive impairment through that vascular pathway. Hypertension itself accounts for between 5 and 9% of the population attributable fraction for dementia globally, and stroke has been identified as the second leading cause of dementia. Also, inflammatory cytokines resulting from rheumatoid arthritis have been linked to neuron loss and accumulation of the beta amyloid plaques, though studies of the association between arthritis and dementia are generally inconclusive. Now, while conditions are often investigated as independent risk factors for cognitive impairment, this single disease approach really negates the reality that chronic conditions often develop in tandem. Multimorbidity, which is defined as experiencing 2 or more chronic conditions at the same time, is one of the most costly and clinically complex age-related health conditions, given the array of health services and pharmaceutical interventions that are required to treat multimorbidity. And this often leads to high patient burden, insufficient care, and then the negative effects of polypharmacy. The majority of older adults with dementia do experience comorbid conditions, so therefore they experience multimorbidity. And this complicates the organization of care that's required to manage multiple and often interacting conditions. Several studies have identified a consistent association between multimorbidity and cognitive impairment, with multimorbidity onset and the rate of accumulation in chronic conditions both being linked to cognitive outcomes. Now, in addition to research where multimorbidity is operationalized as a sum of chronic conditions, there's growing evidence that supports the notion that specific disease combinations have unique links with the risk of dementia and cognitive decline. So as we've kind of talked about today so far, cardiometabolic multimorbidity, which is composed of conditions such as diabetes, heart disease, and stroke, has shown to have a dose-dependent association with the risk of dementia. Also, concurrent hypertension and heart failure have been linked to the risk of dementia. Depression has been shown to act as a potential mechanism that mediates the association between cardiometabolic multimorbidity and cognitive decline. And finally, depression has also been shown to moderate the association between diabetes and the risk of dementia. So there's a lot of, really quite clinically complex interactions between these conditions as they relate to dementia. So collectively, there's substantial evidence that suggests that specific disease combinations increase the risk of cognitive decline and dementia. And this represents both a challenge and an opportunity for those tasked with the identification of effective treatments to support cognitive health. Currently, the link between common multimorbidity patterns and cognitive decline have not been examined among older adults residing in lower and middle income countries, such as Mexico. This gap in the literature is critical to address because the identification of multimorbidity patterns that increase the risk of cognitive decline can inform clinical interventions and policies to address the growing needs of Mexico's aging population. So to these ends, we use the Mexican Health and Aging Study, which is a nationally representative sample of Mexicans in Mexico, to identify common multimorbidity patterns that exist among this population. And then we examined associations between the observed multimorbidity combinations and trajectories of cognitive aging. So as I've said, we used the Mexican Health and Aging Study to address these research questions. The MHAS is a panel study of Mexican adults, which began in 2001. And I see that I have age 60 and above. I'm not sure if it's 50 or 60 now that I think about it, although our sample is restricted to adults age 65 and older. So this MHAS data set is a really interesting and valuable resource that researchers can leverage to examine cognitive change in aging Mexican adults. The data set's valuable because it's both nationally representative and it's also harmonized with other longitudinal studies of aging, specifically the Health and Retirement Study, English Longitudinal Study of Aging, and all of these other longitudinal studies of aging that are harmonized through the global Gateway to Global Aging, which is a really great resource. Now, given there was a protracted interval between interview waves in 2003 and 2012, we drew observations from the 2012, 2015, 2018, and 2021 survey waves using 2012 as what I'll call the baseline measurement. Excuse me. Sample selection criteria for our analyses included being between the ages of 65 to 90 in any of the waves of observation, having complete baseline data on the cognitive outcomes and chronic disease indicators that were of interest, and also having plausible values on the specific cognitive measures. After selecting on these criteria, 6,082 respondents provided around 18,000 person observations to the analyses. Now, to measure cognitive function, we used a modified index of total cognitive function based on the cross-cultural cognitive examination. This tool represents a really valuable resource for cross-cultural investigations of cognitive function, as it was designed to reduce bias in the cognitive assessment of individuals with limited literacy and education levels. For example, all questions were translated, back-translated, and culturally adapted for use in the aging Mexican population. The cognitive index in our study included 7 tasks that were measured consistently from 2012 to 2021. These included immediate and delayed word recall tasks, immediate and delayed visuospatial tasks, as well as a verbal fluency and orientation test. As the range of each of these cognitive items varied and there haven't been validated scales using the CCCE as it's implemented in the MHAS that are consistent over time, we created an index of total cognitive function by first standardizing each item, and this was using the mean and standard deviation for that item at the baseline assessment in 2012. These item-specific standardized scores were then averaged at each interview, and this created a total standardized cognitive score that represents cognitive function in 2012, as well as change in cognitive function relative to baseline for the 2015, 2018, and 2021 interviews. Chronic conditions included in our analyses are those that are persistent, require ongoing medical attention, and may limit daily activities. Specifically, respondents were asked to report if they had ever been diagnosed with hypertension, diabetes, cancer, lung disease, heart attack, stroke, or arthritis. Depressive symptoms were identified using a 9-item modified version of the Center for Epidemiological Studies depression scale. And this has been validated for use among older Mexican adults, specifically the cutoff for depression. Now, to identify multimorbidity combinations, all possible combinations of 2 or more conditions were examined, and those combinations that were experienced by 2% or more of respondents were attained. I want to reiterate, or I guess I want to iterate or make note that multimorbidity was only measured in 2012, so these combinations are not time varying. So those identified with a combination of conditions with a prevalence of less than 2% of the sample were collapsed into a single inclusive other multimorbidity combination group. And due to the desire to maximize sample size, individuals with no chronic conditions or only one chronic condition at baseline were also identified. And respondents with a singleton condition with less than 2% prevalence, they were collapsed into a single group as well. After identifying these multimorbidity combinations, a single mutually exclusive categorical variable was created to identify which combination each participant or respondent was associated with. Briefly, these are the multimorbidity patterns that met these criteria, and I'll talk more about the distribution of the variable in a minute. For covariance, there were several measures we included in analyses to adjust for the potential confounding of the associations of interest. I'm not going to expand too much on them here, but covariates included indicators of demographic characteristics, life course socioeconomic status, health behaviors, and childhood health. Now, to model cognitive change as a function of these multimorbidity combinations, we used a latent growth modeling approach. So for those that are unfamiliar with this method, latent growth modeling applies a structural equation modeling framework to estimate change over time through the specification of a latent intercept, which represents the value of the dependent variable at the initial measurement. And then you can vary that, but that's kind of the typical approach. As well as a latent slope, which represents average rate of change in this dependent variable over time. So to model developmental change in the standardized cognitive index, we actually changed things and used age to identify time in the growth models. This is called the individual data vector variable definition approach for individually varying time scores. This approach essentially shifts the x-axis of the growth model from modeling change in the outcome over the number of years between the first and last waves of observation to modeling change in the outcome over the entire age range of the sample observed across all of the survey waves. To make estimates of change more clinically relevant, these individually varying time scores were divided by 5 so that estimates of change correspond to 5-year intervals. Using this approach, the latent intercept represents the mean standardized cognitive score at the average age of the sample in 2012, which was around 72 years. Now, it's easy to interpret, well, I shouldn't say easy, but it's more approachable to interpret the estimates from a linear latent growth model. But based upon examination of model fit indices, there was evidence that change in cognition was nonlinear over this age range. So this required the inclusion of a quadratic latent slope. This results in a model where the latent linear slope represents the amount of change directly following the initial measurement. They call it the instantaneous rate of change. And the latent quadratic slope quantifies change in the curvature of the estimated trajectory over time. So this addition of the quadratic latent slope does complicate the interpretation of the statistical estimates. So at this point, it's really important to use visualization of the trajectories to kind of make sense of these estimates and the associations that are identified. So this first set of results I'd like to share are the multimorbidity combinations that were identified in 2012. So there were 7 distinct combinations and 4 singleton conditions that met the criteria of having more than 2% of that analytic sample identified. So close to 17% of the sample experienced no chronic conditions, and about 28% of the sample experienced only 1 chronic condition, of which hypertension was the most common, which isn't much of a surprise. The 3 most common multimorbidity combinations were hypertension plus diabetes, hypertension plus arthritis, and hypertension plus depressive symptoms. There were also 4 advanced multimorbidity combinations, meaning combinations with 3 or more chronic conditions. Of all of the multimorbidity combinations, hypertension was a component of all of these, and diabetes or depressive symptoms were components of 6 of the 7 multimorbidity combinations. A fairly large proportion, around 25% of the sample, was identified as having some other combination that didn't meet this inclusion criteria or identification criteria. So in total, about 56% of respondents in 2012 were identified as experiencing multimorbidity. This table presents descriptives for the standardized cognitive index and age at each wave of measurement, as well as some select individual characteristics measured in 2012. There was relatively little change in this standardized index across measurement waves, though these wave-specific means are not adjusted for age and other covariates, so they're not really indicative of change in cognition over time. As I've said, the mean age of the sample in 2012 was around 72, which had increased to about 79 years by the final wave. And notably, about 51% of respondents in the original baseline sample were lost to follow-up by the final survey wave, so really high attrition rate. The baseline measurement in 2012, around 54% of the sample was female, about 30% lived in a rural area. The mean years of education reported was about 4.42, and around 22% of respondents were youth. So now shifting to the results of the latent growth models, this table presents estimates of the association between the multimorbidity combinations and developmental change in cognition that was estimated using these covariate adjusted quadratic latent growth models. It's important to note that a dummy variable was created for each of the identified multimorbidity patterns, and those with no chronic conditions were used as the reference category in the statistical analyses. So if you can see on the column labeled latent intercept, you'll see that there were several multimorbidity patterns associated with cognition at baseline, which really represents the mean age of the sample in 2012. On the other hand, there were relatively few multimorbidity patterns associated with change in cognition represented by the latent linear slope and the latent quadratic slope over this observational period. So, rather than try to make sense of these estimates and look at a table, it's always nice to visualize results. So this is a forest plot that represents the covariate adjusted statistical estimates of the association between the cognitive trajectory intercept and multimorbidity combinations in 2012, again using the no condition category as reference. So note that this is a cross-sectional analysis here. So the association between these measures at the same time. I did have to use abbreviations here due to space constraints, so I apologize for that. Oops, I lost my box there. So compared to respondents with no chronic conditions, estimated cognitive scores at the average age at baseline were the lowest among respondents experiencing a combination of hypertension plus diabetes plus arthritis plus depressive symptoms, which represents the most advanced multimorbidity combination that we identified. Those experiencing a combination of hypertension, arthritis, and depressive symptoms, or hypertension plus diabetes plus depressive symptoms, or finally hypertension plus diabetes plus arthritis, also had lower cognitive scores at the mean age at baseline. Individuals with combinations, got to keep up with this. Individuals with combinations of either hypertension and diabetes or hypertension and depressive symptoms also had lower estimated cognitive scores at baseline than the no condition reference group. And this was also true of individuals who only reported depressive symptomatology at baseline. So moving from the cross-sectional associations identified, we can now examine the significant associations between multimorbidity combinations measured at baseline and change in cognitive function over the entire age range of the sample. This figure depicts the estimated cognitive trajectories for the multimorbidity combinations that differed from the no condition reference group on either the latent linear or latent quadratic slope. And it also includes the observed cognitive scores at each age, which is the red dotted line. And this was calculated as the age-specific mean cognitive score across the 4 waves of measurement, so bringing in as much data as we could. Individuals reporting no chronic conditions or those reporting only hypertension, which are the trajectories represented here by the orange or black solid lines, had similar cognitive trajectories that could be characterized as having less rapid cognitive decline with advancing age. Individuals reporting only diabetes or a combination of hypertension plus diabetes plus arthritis, those solid lines that are represented in blue and green, have similar cognitive trajectories that can be characterized by more rapid cognitive decline with advancing age. So in summary, we found that several multimorbidity combinations were associated with the cognitive trajectories of older Mexicans. This provides insights that can be leveraged to reduce the burden of cognitive impairment in Mexico's rapidly aging population. The associations identified between specific multimorbidity combinations and baseline cognitive function specifically provide guidance on how disease groupings might influence the manifestation of disparities in cognition that emerge prior to older adulthood. Also, the identified association between these multimorbidity combinations and change in cognition provides evidence of potential disease clusters that can be targeted to reduce the risk of subsequent cognitive decline in older adulthood. Multimorbidity patterns associated with initial cognitive function included diabetes, depressive symptoms, or both, suggesting that programs that aim to reduce early risk factor for diabetes and depression, as well as provide treatments for those with diabetes and depression in middle age, may be effective means of reducing disparities in cognitive function that manifest prior to older adulthood. In terms of conditions that may be targeted to reduce cognitive impairment among those already in older adulthood, diabetes appears to play a particularly important role in cognitive decline among aging Mexicans. Now, presenting as either a lone condition or alongside hypertension and arthritis, diabetes appears uniquely associated with cognitive decline in this population. This highlights a potentially serious threat to the cognitive health of Mexico's aging population, given the large and growing number of Mexican older adults that will be affected by diabetes. So though we believe our work benefits from many strengths, there's inherent limitations to our analytic strategy that we want to present. I think foremost, our decision to examine the association between cognitive trajectories composed of measures taken over 8 years of measurement, and then multimorbidity combinations only measured in 2012 means that change in multimorbidity was occurring simultaneous to the estimated changes in cognitive function. So our models don't account for this. Another issue is the use of the standardized cognitive index reduces the clinical inferences that can be derived from the work because the estimates of change in cognition are relative to others in the sample, and there's no identified thresholds for which an individual is experiencing a high probability of dementia. Finally, the results reported here assume missing data in cognitive function was randomly distributed, which is likely erroneous given the strong association between cognitive function and mortality. I will say that we've replicated these results using pattern mixture models, which is a way to address non-random missing data in longitudinal analyses. And generally, the findings were similar across missing data treatments. So the positive takeaway from our work is that both diabetes and depressive symptoms are potentially modifiable. This is through therapeutic treatment, lifestyle modifications, and this suggests that interventions that are seeking to reduce the burden of diabetes and depressive symptoms may be effective in also supporting the cognitive health of Mexico's aging population. Attempts to reduce and effectively manage diabetes specifically may be particularly effective in slowing age-related cognitive decline among Mexican older adults. In the future, we're looking forward to expanding on this work by addressing some of the noted limitations, specifically exploring methods that enable examination of concurrent change in these multimorbidity combinations and cognitive function over time. That's it. So I'd like to thank everybody for your time. I really appreciated being able to present our ideas. I'll finish by saying we have no conflicts to disclose, and we gratefully acknowledge the support of the NIH and the NIA in helping develop this work. Here's my email if you have questions we aren't able to address in the question and answer session. Thank you.